So let's talk about removal of the wound vac dressing. Say the doctor's ready to go to a damp to dry dressing or some other type of dressing. This is pretty much a clean technique. What you're going to do is you're going to turn off the suction. Once the suction's relieved off that sponge, then you clamp your clamp and you can disconnect it from the wound vac at that point. So we have our syringe of sterile saline, and what I like to do, because these can be very painful to remove and they can disturb that granulated tissue that's in the wound bed. A lot of nurses will cut the tubing right here and squirt the saline in that way. And that just helps soak that sponge off the wound. And again, we're trying to keep it as sterile as possible. So again, you're going to protect your bedding, that kind of thing. So our sponge is completely saturated, and this allows the patient to have some more comfort during this procedure. Removal of the dressing is sometimes the most painful part for these patients, especially if they've grown some hair underneath that drape. So again, you're going to use your adhesive remover wipes to help remove this dressing. For this patient. So this is when you would notice if someone just used a single drape and didn't put the protecting drape down first, then the skin, they may have petechiae, purpura, sometimes just like a hickey type appearance in one place or another. And that just weakens the skin integrity, makes it easier to tear, especially with these patients that have shearing issues, and we don't want that. So and on a real person, that foam does not come out that easy. It is usually adhered to that granulated tissue or slough that's in that wound bed. So I'm going to ball this up in one hand, the hand that it's stuck to, obviously. And so at this point, I know I'm going to go straight into a damp to dry dressing. So I could go ahead and clean it. With take out the water, saline, I mean, clean the skin around, and then finish taking my dressing and double bagging it in my clean gloves. So again, you're assessing that wound bed for redness, ecchymosis, erythema, drainage, and of course we're not going to have approximation. This is an open wound, so just remember that RITA acronym. And then as we go into our drainage, we're assessing for that caca, for color, amount, consistency, and aroma. So at this point, I'm going to apply my sterile gloves because the clean work is done. And this is when I can come over here and grab, didn't really turn my back on my sterile field, but I can grab me some 4x4s, and then I can use my tray to pour my saline on for my damp gauze. Because it's still sterile on the inside. And now I can apply my other sterile glove. Okay, so I'm going to take this gauze. If I was using a saline at this point, I could get it moist. If I'm using a bowl or a container or the package, then I can just dribble some on there. Let me bring this over here. So I grabbed it so that I didn't contaminate myself. And I'm going to set it over here off my sterile glove package. I really want to squeeze that gauze out. I just want it damp. And you really want to make sure this is very loose packing. Again, you're staying within your sterile field, your range between the shoulders and your waist. And unless you've got giant fingers, you really don't need Q-tips, except for smaller wounds. If you need, for exploring the wound bed, that kind of thing. And then I can use my fingers just to kind of feed that gauze in there, keeping it controlled with one hand. If the wound's big enough, or if you're using a smaller gauze, then you can drop it in the wound and then spread it out with your sterile glove fingers. That's probably the way I prefer it. But with such a small wound, it's hard to do that. And then we tape, and the patient is good. And you're going to go through your 8-its. And that's all, folks. Clean up. Remove gloves, hand hygiene. Put your patient back in a safe position. You know the drill.